Okay, we're on to part 3. When the fetus needs help becoming a newborn, this is when we would do an assisted delivery or an operative delivery. That includes vacuum extraction, forceps, cesarean section. Um, okay, so these types of operative deliveries are indicated when birth needs to happen immediately or when mom is too tired to continue pushing or is not progressing in labor even. Um, we also do it for non-reassuring fetal heart rates like bradycardia or decelerations. C-section could be done for prolapsed cord, failed operative vaginal delivery. We've tried a vacuum or forceps and it hasn't worked, and now the baby needs to come out. Worsening maternal conditions, for example, if mom has chorioamnionitis or an eclamptic seizure, or her pressures are elevated to the point where we're very concerned about her preeclampsia. But it should be considered very carefully. Each one of these procedures has additional risk, so we need to make sure that the benefits outweigh the risk. Vacuum-assisted vaginal delivery is the application of suction to the fetal head to effect delivery. This is only good during second stage. Mom still has to push, and you do not put pressure on the fundus or top part of the uterus ever with that. You should see progressive descent within 2 pulls, meaning the baby's head should be lower. Pop-offs refer to when that suction is applied, and it's a lot of suction, to the head, and it forcibly pops off the head. You can hear a sound even when it happens. So there are risks to that. You should not have more than 3 pop-offs. If that happens, the indication is for C-section. You don't go to forceps. We don't mix operative deliveries. Those have very poor outcomes. We would at that point go to a cesarean section. The risks to the baby include cephalhematoma, fetal brain injury, fetal death. Risks to mom include damage to the tissues, especially if her tissues get stuck between the suction cup and the baby's head. So that's part of the procedure. They should be making sure there's no vaginal tissue inside the suction cup. And also damage to the bladder if it's not empty. Okay, so there's your kiwi. That's what it looks like. It's a little soft, spongy thing. And that hand pump, the provider does that themselves to get it to that green part. That's where the maximum safe pressure is. Any less than that, you're probably not going to help that baby come down. Any more than that, you run the risk of injury. And this is a mighty vac. This a nurse would have to assist with. See the handle? We would pump that up into that green zone right there. There's the cup that's applied to the baby's head. There are different types of cups that can go with the mighty vac. But anyway, so your nursing responsibilities would be to make sure that the bladder is empty. If the mom did not just have a Foley, you're going to straight cath and make sure that bladder is completely empty and out of the way. Your job is also to monitor the fetal response to this intervention. Some babies really decel during the application of the vacuum. And you're going to note time of application. And so either someone's standing at a computer logging it in, or if you're running a strip, you can mark the strip. The length of time that the pull occurs, any pop-offs, and you're going to document whether or not the baby is coming down. For the mighty vac, you also have to pump up that handle and stay in the green zone. And you also have to call NICU to come to that delivery because babies might not tolerate this procedure real well and might need a little help getting started. Here is what it looks like when you take that cup off the baby. There's that nice little red ring. Now, for our next section, we're going on to forceps. That is forceps marks. They're like salad spoons, and they're applied to the baby's head. They run along the cheeks. And that's the salad spoons. That's what they look like. That's why they create that pattern injury. We use forceps about 1% of vaginal deliveries. They do require specialized training. People who are not familiar with forceps should not be using them. There's 3 types. It depends on how low the baby is. There are outlet forceps that are not as big. That's for when the baby is crowning. The application of those forceps is much easier. Low forceps are sort of halfway between when the baby is +2 station or more, like it's made some descent into the birth canal, but it's not crowning, so you have to have like longer handles. And mid forceps when the baby is engaged in the pelvis, but not necessarily descended into the birth canal. Risks to the baby: fetal head or face injuries, skull fracture, brain injury. Risks to mom: 4th degree laceration of the perineum. I used to have a preceptor who told me forceps fourth. We were about to do a forceps delivery, and she went to grab an instrument that is used to repair fourth-degree lacerations. And she said, forceps fourth. And so that's how you can remember it. Perineal hematoma, bladder injury to mom, and if she has an extensive fourth-degree laceration that isn't repaired correctly, she can suffer fecal incontinence, and that's, an unfortunate complication. Another intervention we can do, usually in conjunction with a vacuum or forceps, or sometimes just when we have tight perineal tissue and that baby needs to come out, is an episiotomy. It's a surgical incision into the perineum. Use a pair of scissors to do it, and it just gives you a little more space for delivery. Indications, the old indication used to be, well, if you don't do it, she'll tear, and honestly, there were lots of women who had episiotomies and lacerations. It reduces the length of second stage by about 15 minutes, and it allows for instrumental delivery, creates a little more room, and increases your chances of getting that baby out with that 2 pulls, 2 or 3 even. Okay, so here are the different types. This red incision here that I'm pointing to, that's midline. The advantages are that it heals faster and better, because right there it's not muscle tissue, it's a ligament joining 2 muscles. And so it will heal faster. It's less uncomfortable. Disadvantages, it does not make as much room, and it may extend into the rectal mucosa. Sometimes you get an extension, sort of like when you cut into a piece of fabric and then you can tear it down. So there is that. Medial lateral, the advantages, there's no rectal involvement usually, and you can make more space. So providers might select this option if they know that they need more room to get this baby out. They suspect a large baby, and baby's got to come out now. Disadvantages, it heals slowly, there's more pain, and there's greater blood loss. And that episiotomy scars of both types may spontaneously be lacerated with the next delivery, because scar tissue is not as elastic as intact skin, or skin that's allowed to heal normally. We're moving on to cesarean birth. It is the most common surgical procedure in the United States. It accounts for more than 1/3 of all births in this country. It is a major abdominal surgery. It involves higher morbidity and mortality, but sometimes it is the safest thing. So the World Health Organization estimates that between 5 and 15% of births across the world will require intervention with a cesarean birth. If you have more than that, you're probably doing them unnecessarily. If you are doing fewer of them, you probably don't have access to safe facilities for cesarean birth. The nurse's responsibilities in a C-section, pre-op education, positioning for spinal, and then we'll talk about the role of the circulator, I think, on the next slide. Insertion of a Foley catheter to prevent bladder injury, maintaining and monitoring the sterile field, that's a big one. Managing equipment and obtaining supplies. So you're the one in charge of the suction, the bovie, counting sutures and laps, and placing them on the sterile field. Because once your scrub tech is, gloved and gowned, they can't open packages that are not sterile on the inside. And you're going to count a lot. The risk is that you could leave an object inside the patient, which could cause massive infection. And other problems, damage to organs. So you're going to count things before you start, and then you're going to count them at different places in that procedure. And you'll probably see some of that in clinical if you're fortunate enough to see a cesarean section. But those are big jobs for the nurse. And we are going to stop there and move on in a minute.